All right, good afternoon, everybody, and welcome to the Board of County Commissioners Workshop. Would you all please rise for the Pledge of Allegiance? I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, first up, we have Mr. Joe Theine with us to give us an update on SHS, Southwest Health Systems.
Great. Thanks for the opportunity as always. A couple things I'll go through relatively quickly just to give you kind of a status on how we're doing with some longer term plans. I'll pause for a moment to talk a little bit about our cash position, and that also ties into how we're thinking about the upcoming future and some of the things with HR1. So if you want to go ahead to the next slide. This is just a reminder, last year we ended with a positive operating margin for the first time in a long time. So far in 2025, our operating margin is right about where it was at the end of last year. And if we have a couple of months like we plan to between now and the end of the year, we'll finish with a higher operating margin than we did last year. So financially, bringing some stability to the organization. If you go to the next slide, this is looking at a variety of different services we provide in the hospital, how much we plan to grow versus where we're growing year to date. A couple things to keep in mind: the growth that we planned was for the whole year. Where we are in the middle of the year is not quite the end of the year. We did have a little bit of a slower summer in some areas of the hospital, in particular patients being admitted on an inpatient basis. So you'll see some of the volumes are a little bit lower than where we planned for the whole year. And then there's some areas where we continue to be growing at an even faster rate than what we planned. Diagnostic imaging is one of those areas where we continue to have more people seeking care from us than we had planned. And then observation days, so that's still a patient that spends a night in the hospital, but they're not admitted as an inpatient. Their status may be such that they can't readily go home. They need a little bit closer care for a period of time. We can't admit somebody for more than 24 hours in an observation status, but they are occupying a bed in the hospital. So while the true inpatient volume was lower than what we expected, we still had people using the hospital, just not needing to be there for an extended period of time. So overall, we're pleased at how we're doing so far this year. Go to the next slide. Continue to monitor how we're doing with our overall employee retention. That dropped a little bit at the beginning of the year, but is leveling out and still about 10 points or more higher than where we were at a low point a couple of years ago. Don't have a graph for the nursing retention, but it's also relatively stable. Our nurse retention's north of 80% through the last 12 months. So continue to do a nice job attracting and retaining nurses to the organization.
I got a quick question on that, Joe.
Yeah,
Do you
Jim.
have a national average? Is that, 74% seems still pretty good. Is that?
Yeah, if
That-
the last national average data we had was at the end of 2024, and this would put us somewhere kind of in the middle of the pack, more or less average with most hospitals across the country. Our nurse retention rate, when we looked at that last year, was much higher than the national average. So the work we've been doing on our nursing team is really paying dividends.
Okay, good.
Next slide is just kind of a reminder of where money comes in for us. Most of it is fees for services we provide. Continues to tell the story of how important it is for people to choose to get health care locally when it's something we can provide. And then, as we continue looking at where funds are going to flow from in the future, 17% of the fees we collect come from the Medicaid program. When we add the monies that are fees paid by hospital, they get matched to the federal government side and come back to the state and then ultimately to the hospital. That represents about another $9 million. When we add that in, it would go from about 17% to 25%, almost 24%. So still highly dependent on Medicaid as a funding source. Go to the next slide. This is a picture I shared early on in my tenure, and I think it's really helpful for us to be thinking about as a community, again, the importance of getting care locally, but also as finances over the next several years get tight, how we have to juggle three priorities in terms of where our investment goes. So we have to have a physical building, we have to have supplies and equipment, stuff for people to use, and then we have to have people. And so as we're looking out and planning for the future, trying to make sure we're balancing that investment so the building stays strong and tall and is well taken care of. On the supply side, depending on what happens with tariffs and healthcare, that could increase our costs more than just the rate of healthcare inflation. And then we have some aging equipment that's going to need to be replaced in the years ahead, and I'll talk about that in a moment. Days cash on hand, if you look at it on the surface, we continue to grow cash. We're now at 114 days at the end of August. I think it even ticked up another day or two at the end of, that's the end of August. So 114 days. Of those, some of the monies are restricted for the building. So those two blue bars are either related to the bond debt requirement that we have, or it's funds for fixing, repairing things that are related to the building. When you strip those two reserved accounts out, there's still 87 days of cash that we have against a 60-day requirement from the bondholders. If you go to the next slide, I've been sharing that we know we have to spend some of that 87 days, and so some of that money is being held to help prepare us to make an electronic health records transition early next year. We'd hoped to do that this year. We've literally just signed the scope of work in the last couple of weeks. We'll start doing some of that work this year, and then it'll continue into next year. That'll move the outpatient clinic's electronic record onto the same system we use in the hospital. One of the benefits for patients, if they use a portal or they pay bills online, they'll have one place to go to for all of that information. Internally for us, it really creates the same record regardless of where the patient is, which makes the providers' work a lot easier in getting and exchanging information. So that work will take place early in the year. We've reserved about $1.3 million to work through that changeover. Part of the way rural hospitals get paid that are critical access is on a cost-based reimbursement. What that means in my layperson's terms, it's kind of like taxes. Throughout the year, we're paying an estimated amount, or we're being paid an estimated amount, just like we would on our federal taxes. And then at the end of the year, when we know what our true cost of delivering care was, we file a cost report, or the equivalent of a tax return. Throughout the year, we have an idea of how our costs are shaping up and what that means for reimbursement. And so we know right now that we may be overpaid for some things we've done based on our actual costs. So we're holding on to some cash, knowing that we'll have to return that. And then just like with our tax returns individually, you can go back and refile tax returns for prior years, or the auditors can come and take a look at those things. And we opened up some cost reports for prior years. That got us some additional funding from Medicaid, and we have to pay some money back to Medicare. We've already received the Medicaid money in the door. Medicare hasn't asked for that money back yet, but we know how much it is, and so we're holding that cash. When you add a number of those things up where we're holding cash, but we know what we're going to spend it on, if we were to spend it all today in one fell swoop, what we would be left with is about 11 days of cash on hand above that 60, or about $2.3 million. So we're still operating the hospital as though we have very little cash, rather than operating it as though we have 114 days. So being really thoughtful. There's also some things that we know are coming, but we don't know what the impacts are going to be on future cash flows. So the CHASE program is that program where hospitals pay a fee, it's matched federally and comes back. We know in the upcoming years that federal match is going to start declining. We don't know how the state's going to change their program to allocate funds, but we expect that it will be less funding coming in. We're doing some work right now on our physician and advanced practice provider compensation, and we expect that we're going to have some additional investments that we're making in paying the physicians and advanced practice providers. That work's ongoing at the moment. On the federal side, assuming that Congress doesn't act, and beginning next year, the enhanced premium tax credits that came about through the Affordable Care Act will go away, and premiums will go up for individuals purchasing insurance. We expect that means there will be fewer people that are purchasing insurance. It doesn't mean that they won't need care. It just means when they present at the hospital for care that there won't be a source of payment other than if they were going to pay cash for that. So we expect that to have some impact. And then beginning in 2027, we expect Medicaid enrollment to change with work requirements and other things. We just, again, don't know the magnitude of what that change will be.
So, Joe, I got a question on that real quick, because how do we get the message out that people, if they need care, they should still go, they can still pay for it themselves.
Correct.
I mean, they don't have to have insurance if they can't afford it, because I get it. If it goes up again, your health insurance is gonna, I mean, I know what we pay per employee here.
Yep.
But people should still seek care for their benefit, and that you all still can figure out a way for them to get
Yeah, we're gonna
it paid for.
We're going to take care of anyone, whether they are insured, don't have insurance, whether it's Medicaid, Medicare. So people should still come and seek care. We have a financial assistance program for the hospital. So depending on somebody's income, they may pay less, depending on their income level. But there's not another source of revenue that offsets that.
Right.
So it does reduce, the overall payments that the hospital receives.
But they can still pay for it themselves,
Yes.
even though, okay.
Yep, absolutely. There's some positive things that we don't know what the full impact will be. We're starting to plan for it. And I'll touch more on cardiology and oncology and why we think that those two service lines are going to continue to be kind of a tailwind pushing us forward rather than all the headwinds that we have. So just know that we're being really thoughtful about using the cash that we have in the bank and still being really diligent about running a lean operation. Go to the next slide. Go ahead and go down a couple. There you go. So again, our board's got us really focused on two really important long-term goals. One is to improve the health of people who are part of our community, and the other is to make sure that when something urgent or emergent happens, that you can get care with us. If you go to the next slide, we're continuing to really look at internally our people in service. That's one of the reasons why that retention number's helpful for us to monitor. We believe when we have the right people providing great service, we end up with safe, high-quality care. People will want to continue to come in greater numbers to receive care, and that allows us to do great things. So that's the underpinnings of our planning. One of the ways we're looking at how we can impact people's health is, are people accessing a primary care provider? There's about 30,000 people in our service area, not all of whom we would expect to come for us for their primary care. Our service area includes the U-Mountain Ute, who are going to get their primary care through IHS, and we've got other primary care providers. But we do think that number should be growing month over month, year over year. And what you'll see is, starting earlier this year, the number of people who have seen a primary care provider in the last year is continuing to increase month after month. And we believe if somebody's accessing their primary care provider, that's likely going to lead to more preventative care, better management of chronic conditions, and ultimately improve health. So that's why this is something that we're sharing with our board on a pretty regular basis. Some other things that are happening, if you go to the next slide, to help improve that access to primary care. We had 2 new primary care physicians, or 1 returning and 1 new to the area. Primary care physicians that started late this summer. So Dr. Smith returned to the area in July. Her practice is busy. A lot of people that she saw in the past have come back to see her. And then beginning in September, we have an internal medicine physician, Dr. Melhem, who joined. A fun story about Dr. Melhem, he, in his early days, was living and working in Colorado, so he actually did some work up at Purgatory on the ski hill when he was younger, and he guided rafts in Salida. So he's got some really good connections to Colorado and to rural communities before going off to medical school. So excited to welcome him and his family to the area. Go ahead to the next slide. One of the spaces where we've been looking at expanding care is to increase visits in Mancos. So prior to this year, we were only open Monday through Thursday. We didn't have Friday hours, and we also didn't provide any prenatal care out of that clinic. Our foundation raised money, and we were able to purchase an ultrasound for obstetric care early this year. Dr. Megan Viquez, who's a family medicine OB provider, is working out of the clinic on Fridays, so we've opened up on Fridays, and then she's providing prenatal care out of the clinic as well. And we've seen the visit volume go up as a result of that change, so we know we're helping people access care in the community. If you go to the next slide. Thanks. The other piece that we're looking at is, once somebody has a primary care provider, and if they have a lot of chronic health conditions already, how do we help people manage their wellness or their health in between the visits with the physicians? And so we've stood up a relationship with a group called the Community Care Alliance. For Medicare Part A and B recipients, there's a payment from Medicare for services like this. So we've launched this with Medicare patients. They can now access a nurse in between visits with their provider. The nurse works remotely but has access into the electronic health record. They can see all the things that the physician or advanced practice provider has done. They can engage with the patient. They'll document their conversations or directions to the patient. If for some reason the physician or the advanced practice provider needs to get looped back in, they can either message directly in the electronic health record, or they can reach out to the MA or to the physician to help facilitate that care in between visits. And so we launched that late in the spring, early in the summer, and we've had a number of patients already enroll in that service. One of the other things we'll be doing internally is adding that to our employee benefit plan next year, so our employees will have access to that same service if they have chronic health conditions. And then later we'll be expanding some of that work into other areas of care management. Go ahead. On the emergency side, a couple things that we're paying attention to are when somebody does come to the emergency room, are they being treated? There's a national standard that less than 2% of people who present in an emergency room would leave without being seen or treated. There's a variety of reasons why somebody may leave. We generally run at half the national standard. Very rarely do we even get close to it. So it's something we continue to monitor to make sure, again, when there's an emergency or somebody presents, that they're getting care. And then if you go to the next slide, the other piece we're keeping an eye on is when somebody does go to the emergency room and they need to be admitted to a hospital, are they admitted to our hospital or transferred somewhere else? We wouldn't expect everyone to be admitted. There are certain things that we can do and certain things that we can't. But we're starting to look at, are there ways in the future that we can expand our capabilities so more people can stay in their community and get care when they do need to be in the hospital? But right now, we're just kind of monitoring our baseline, so as we make changes in the future, we know if they're having an impact in helping people stay locally for care. So I mentioned I'd talk a little bit about cardiology and oncology. So earlier this year, we purchased some new ultrasound equipment to do echocardiograms and a new stress test system. We also started working closely with the cardiology program up in Montrose. We've had a cardiologist from Montrose in our community most months of this year, and they're now on a very regular basis here about a week to a week and a half a month. We're still actively recruiting for both a full-time physician and a full-time advanced practice provider to live and work in our community, and that collaboration with Montrose continues. What we've seen with the team from Montrose delivering more cardiology care in our community than what we've had in the past is an increased use of the diagnostics that we have at the hospital. And so patients, when they're seen here, tend to get their tests done here. That's saving them, trips back and forth to Durango for things that we can provide here. And when we look at the second quarter this year compared to the end of last year, we've already seen about a 40% increase in cardiac diagnostic tests. We expect that to continue to grow, and first and foremost, that's helping patients get great care right here without having to travel. And then financially, that equipment is already purchased, it's already there, we already have the staff that are trained and able to use it, and we have capacity to care for more people. And so each time somebody chooses to get that test done here, the revenue really goes to the bottom line for us to reinvest in other things because the costs are relatively fixed. So really pleased to see that. We expected this to happen as we started working more closely with the team from Montrose, and it is happening, which is great.
You anticipate somewhere down the road of doing invasive surgeries?
Like cardiac catheterization,
Yeah.
it's not in our foreseeable future.
Okay.
Never say never, but that's not on the
Right.
planning horizon. Yep. The other thing we are looking at is we will be replacing our CT scanner in the next few years. It's reaching its end of life and will need to be replaced. There's some cardiac imaging that's more commonly done with CT now than in the past, and when we upgrade that CT, we'll be able to do more cardiac imaging studies than we do today. To help us get ready for that, the pictures that you see here are a planning effort that we've done. We engaged with an architecture firm and the engineering firm we've commonly worked with to look at our whole diagnostic imaging space. And as we get close to replacing our CT, our MRI, some other equipment in the area, we wanted to have a thoughtful approach about both how we stage that and how we use the space. So we had a team of our staff, our physicians, folks from clinical and non-clinical areas come together for a day and actually plan on how to use the diagnostic imaging space. We think over the next several years, if we can stage some things properly and be thoughtful about reusing space in different ways, we may actually be able to add some services when it's all said and done. Like I said, the first step in that process is going to be replacing the CT scanner in the next couple of years. The MRI and some other things will probably follow that.
Gonna have to knock a hole in the wall?
We probably will at some point. MRIs often go in and out through a rooftop,
Right.
so we'll see. So we're starting to plan for that next phase of capital equipment, but it's tied back to the cardiology program because we'll be able to do more cardiac imaging in the future than we do today.
Cut a hole in the wall and run a Connex up there, I guess.
Perfect. If you go to the next slide, this is looking at oncology. So we've been talking with the team at Mercy. We invited them out earlier this year with the premise being we think we have a great infusion center. Patients tell us that, but most patients that go to Durango for their cancer care don't come back here for infusion. So we invited the team from Mercy and said, we really want one of two things to happen. Either you see what we see, which is we have a great infusion center, and if it were your family member that lived in Cortez, that you would have them get their chemo here and not go back and forth. Or if that's not what you see, tell us what needs to change and help us get there. And when they left, they were really impressed with the infusion program we have. And since that time, beginning really March, April, we've just seen a consistent increase in the number of patients being referred for chemo. Infusion care. And what's great is, one patient, usually a course of chemo is over a number of weeks and usually several times a week. So for each patient, it's not just one visit for infusion, it's really reducing the number of times that they have to go back and forth to Durango, by a tremendous number. So we're really excited. The team at Mercy continues to have great things to say about our staff. Our staff has had great things to say about their team. We've had some of our nurses and pharmacists go over and work side by side in Durango, and so there's really a good clinical partnership that's forming to the benefit of patients in the hospital.
I know it's much appreciated.
Yeah.
How long has the infusion center been going? It's relatively new, isn't it?
3?
I don't know.
4
It's-
years? 4 years?
It's been at least since we opened the new wing of the hospital or shortly after, because when the new wing opened in 2018, the infusion
went
center is
upstairs.
embedded in where the old hospital beds were at. So it would have had to have been, if not,
6 years?
yeah,
Yeah.
Relatively.
yep.
relatively
And we
new.
infuse a lot of things that are not chemo.
Right.
It's pretty busy, but it's great to see that oncology piece get picked up in a meaningful way.
Okay.
And then kind of the last thing that, remains uncertain to us is, what are the future impacts of, the One Big Beautiful Bill or HR 1 going to be? Generally speaking, we know that over the next several years, especially beginning in 2027 through 2032, we'll see dollars get smaller coming into the state, and presumably that'll mean, less revenue to the hospital. The tailwinds, that we're trying to, help people get care closer to home, really around oncology, cardiology today, but still looking at other services we may be able to bring in on a part or full-time basis. We hope we can provide enough care and grow revenues faster than what those cuts will be. But certainly, there's a big TBD about what the next several years are going to look like in terms of federal funding. And I'll end with the picture I always put up, which is when we're working together, we can create something that's much more beautiful than when we're all doing things on our own. And at the moment, I think there's a lot of great work happening together in the community, people seeking care from us, and growing services and partnering with other healthcare providers in the region. Happy to answer questions, whatever's on your mind.
I have one,
Yes, sir.
because it'll relate back to that last picture there. It seems like the question is, how are the boards working together and are you full? From the outside looking in, it seems like they are meshing a lot better now. I think your boards are all full, MCHD and SHS.
I think MCHD needs one.
Correct. There's one vacant seat on the district board. The hospital board is full. Shirley Jones will be term limited, so I think tonight there's actually a couple of folks that have expressed interest, so the nominating committee is interviewing a few people this evening for the SHS board. Presumably this fall they'll make a recommendation to the board, and the board will appoint somebody to fill Shirley's seat. beginning next year. And the foundation has a full board as well.
Good, because it
Yeah.
seemed like after, I don't know what it was. It was,
It's all run
this,
together.
this room was full.
Yeah,
But it seemed like that contribution as far as working together to try to get everybody to work together more cohesively, seems like it was positive. So
Yeah.
that's
and-
good to hear that they're full, because at that point in time, they were
yeah.
pretty minimal.
Yeah.
They
And
were at opposite ends of the room.
And both boards are working really well together. That planning for our CT and that diagnostic imaging space is a really good example. There's some infrastructure in the building that's aged in that area. And so part of that planning process is how do we time projects where the hospital needs to replace equipment, and can we do it at the same time that the district, the funds that we have through the infrastructure fund, we can use those monies to deal with the building that's, and parts of it that are aged. And so both boards have a representative in that capital planning process so that we can figure out how to mesh funds and actually have it cost less to be doing those projects together rather than doing them separately. So again, it's just one good example of how the two boards are working together to do what's best for the community.
Well, like I said, from the outside looking in, I don't get any calls anymore, and I haven't for quite a few months, but
No,
there
it's
for a
good.
while it was
Constant.
pretty constant. But
We'll
it's
reach out
way
anytime,
better
good or
now.
bad.
Yeah.
Way better now, so I appreciate that.
Well, thank you.
I just received an invitation in the mail from the foundation
Mhm.
for an event, but I can't remember the dates and the time. I looked at it and didn't really, Carla sent it to me. So do you know what the dates are for that?
Not off the top of my head, but I can find out really quick.
I'm still mad at her for retiring, but that's a different time.
I still don't have a physician.
Is that right?
I don't think so.
I can help you out.
All right.
You're gonna have to pay up front, though.
I figured that.
No smoothies either.
I believe it's Thursday, October 23rd.
Okay.
I don't recall the
think that
exact time.
sounds
I
right.
blocked off the whole evening on my calendar, but it'll be at the chamber space right here on
Right.
Main.
Okay.
Um,
Big event.
And it's
I
a
got that.
great opportunity to thank donors who have been contributing and thank a lot of our local elected and appointed officials and share some of the good work that the foundation's been doing to raise money this year. Awesome.
Okay, that's, anything else, Commissioners?
No.
Good.
Thank you.
Okay,
Thanks for all you guys are doing. We appreciate your help and support.
Thank you.
thank you for the update, Joe.
You're welcome.
Next up, we have Miss Hargraves with Social Services, which we can look at the minutes and financials right now, but we won't approve anything until tomorrow.
Do you want me to come back tomorrow?
No,
You
unless
don't,
you really want to.
you don't need to
don't.
come back.
I don't.
Oh,
You can present it all, we're just not gonna sign anything,
yeah.
and I'll sign them tomorrow until we approve them, because this is just a workshop and we can't vote today.
Yes, I was just hoping I wouldn't have to come back tomorrow.
You do not have to come back. You can present everything today, and we'll probably put you in the consent agenda and sign all the papers tomorrow. So go ahead.
You don't want to approve the financials?
I can't.
We can't.
Or, yeah, we just usually have a
Did-
process, like
didn't-
these things
I
occur.
know, but this is Monday. This is a workshop.
I know, I'm sorry, let me
I can do that on
refocus.
Tuesdays, but I can't do it on Mondays.
So you have the financials for social services, usual expenses, nothing different or out of the ordinary. As far as all of the financials, senior services and transportation are included, not because they have to be improved, but in an effort to continue to be transparent about those funds. I know that we've had budget discussions and nothing's been formally approved. HICPUF did reel back their allocation, so they issue those allocations in June, at the very end of June, so that we can plan our fiscal year. Due to HR1, there's been lots of cuts, and so they have let us know that they are going to cut the HICPUF administration allocation. They were supposed to have that to us by tomorrow, but they have told us they're not sure when they're going to be able to let us know the impacts. So if those are cut, which is my assumption, I'll go back and redo the budget to make sure that it still aligns. But it's more of just we expect those cuts.
Because those are just percentages, right, that we use for administration on that program?
It's an 80-20, but the important piece is whatever we spend over the allocation is 100%. So we don't want to overspend that allocation.
Right.
And so everything needs to fall within that so that we have that 80-20 fold. And it's very difficult because they're asking us to do more with less. As you all know, HR 1 requires us to do Medicaid renewals every 6 months instead of annually, which means we're doubling our work. We know that about 15,000 folks in Montezuma County access and utilize Medicaid. That is a lot of additional renewals throughout the year. And so there'll be lots of different impacts, but cutting the HICPUF line, so all those eligibility technicians that are doing that work, can be pretty devastating, not only to requalify folks and ensure they're receiving Medicaid when they get it, but to keep up with the timelines mandated by HICPUF. Does that make sense?
Mm-hmm.
So it's a hurry up and wait. I don't know what that's going to look like. HICPUF did cut transportation for NEMT rides again. So we will see a 53-cent and 58-cent cut to what's already been cut. It was $6 for NEMTs out further than 27 miles. It's now $3. And now we'll reduce it by 53 cents, and then local it'll be 58 cents less. So we continue to see those hits in different aspects of all things Medicaid, HICPUF land. I just returned from COSTA conference, the fall conference. That's Colorado Association of Transit Agencies. It was really informative. It was good for me to go. Transportation's not necessarily something that I was prepped and ready for, so it was great information. I did learn about the brokerage system. It sounds like HICPUF has a broker. They haven't formally announced that because they're still in the argue phase of the RFP. I think it was closing Friday. So they haven't announced yet, but that sounds like it's allegedly going to be better than the system that we use now. That will begin July 1st next year. And that broker will also be responsible for our Medicaid billing as it relates to NEMT. I, of course, have concerns. It's based on preference, so the member calls to get their ride. They have to call the 1-800 number. They have to go through that system, and as we know in Montezuma County, it wasn't popular the last time it came around. And then they get to choose who they want to drive if they say that. Otherwise, it's going to be assigned to whoever has the availability and accepts the ride. And much of that will be based off some key performance indicators. Are we timely for rides? Are we timely to pick up? How are those going? And so our new system that was you guys recently approved will really help us to know what our performance indicators look like, because right now we're not tracking that information. But once we begin using that system, we'll be able to see that and at least begin preparing, because if those key performance indicators are low, we won't be the top of the list. And if we deny rides for whatever reason, it also impacts us negatively as far as getting assigned to those NEMTs. And those NEMTs are much of what MoCo does. That's a large portion of the business that we run. So mostly it's planning and preparing, but it was really great information, good insights to go down there. Last, I wanted to say, just as a general update, I am on Mancos Town Board's agenda for October 8th, that evening, to talk about senior services and make a funding request. I did reach out, finally got in touch with Heather. We had a really great meeting. And I am on Dolores's Town Board meeting scheduled for October 27th to make a request for senior services. So,
Are they having a planning meeting tonight?
Mm-hmm.
Pretty sure it is.
Dolores?
I think so, yes.
Maybe. When I reached out to them, I asked if it would be
Yeah,
timely.
It's a special budget meeting. It was supposed to be last Monday, but they canceled, so that's my 5:30 meeting tonight.
Well, that's interesting. When I reached out to Lee, a while back. She gave me this date and also indicated that it would be within time to have that budgeted into the 2026 year.
Well, I don't
If
know what
there
you're
was any-
doing at 5:30, but obviously I'll be there at that meeting also because it's in my district, but yeah, they are having a budget meeting tonight. It's not their regular board meeting, but they're having a budget meeting tonight.
Sure. Well, and I let her know. I mean, I told her the number, and she said it was. I'll have to see what I can figure out and listen in.
Okay.
But that's really. It feels like there's everything's going well. Things continue to run and move and shake and all that good stuff.
Okay. All right.
I think one other item, unless I missed it, was the Hotline County
Yes.
Connection Center contract.
Yes.
Did you want to talk about that at all?
Yep. So we received our annual contract for the hotline. I was a little surprised to receive this contract because it was 28% higher than last year. That's a gigantic leap. I did email with the hotline center about this gigantic leap, and he indicated that this was necessary. They hadn't risen the rates much in the past. Last year, for 2024, we saw a $1 raise from 2025 per call, which wasn't much, but basically indicated that there wasn't wiggle room, that this increase must happen to keep staff, to continue to grow, to continue to meet the needs of the communities. And so the hotline takes in all of our calls. We're mandatorily obligated to have a hotline, so someone who will take child welfare referrals 24/7 as well as adult protection referrals. If we staffed it and manned it ourselves, it would be greater than what this contract is, although I'm still surprised to see the increase. But this will take place, this will be effective in January, and this is their proposed contract, which covers our child welfare and adult protection referrals. The system of making those referrals.
Have you looked at this?
So,
Do you know how many counties they contract with?
A lot. I would say the vast majority of the small and medium counties. And they all saw this same increase because we talked about it in our directors meeting because we were all very surprised to see such a high increase in a year. Yeah, it's definitely a monopoly there. I thought about how can we break off and have our own regional, maybe hotline, and regionally share those expenses. But I also think then we would have to have some additional systemic things in place that would also cost money.
No other providers we can look at?
I am not aware of any other hotline providers. The big counties have their own hotlines.
Yeah.
And many of us, balance of state counties, run it through the HCC.
so your recommendation, we really don't have any other choice.
We don't have a choice unless we wanted to man it ourselves, and certainly we couldn't pay for 24/7 phone access. And technically, during business hours, Monday through Friday, we do field our own referrals. If they don't call the hotline, they can call us, and we will field them and do the process. But it's those after business hours until we open our doors, and weekends, holidays, and it would have to be manned 24/7.
So will that come via DocuSign or will
Nope,
this just be
I
a
have it
hard-
here for you
Okay.
to, if that is approved tomorrow, it would be ready to rock and roll.
Okay.
That's a big increase.
Yeah, the contract amount is $15,840. And last year it
From
was
12,000, right?
right around 11,800. But I asked for some data on the call logs. Certainly, I know we're getting a lot of referrals in child welfare, so it doesn't surprise me that those have increased. I was more interested to know if the APS referrals had increased. I pulled all of our prior year's contracts and sent numbers and asked for some data. He did not send me the data, but did basically indicate that we weren't going to engage in any dialogue about reducing the increase this year.
Do they go through an audit?
No, we
Yeah.
get that. We get all of the audits on every level,
Yeah,
every level.
okay.
And it might be worthwhile for over the next year, and certainly I think it's also a capacity issue. I think that we could potentially build the infrastructure needed to man something regionally. And I could absolutely have those conversations over the next 12 months with those directors nearby.
But regionally, I mean, when you still look at the value of that $15,000, I mean, we've got at 3:30 an E911 board meeting, and our capacity last year per call was like $76, $75
yeah.
per call.
Yeah.
And that only has like 11 users on it, correct?
There's more than that.
thought
But
it was
primary
11.
users is about 11, but there's some outlying users.
Yeah, but they're so small, they're like 1-2%.
Right.
What would it take as a region to have something that's a 24/7,
I mean-
like our dispatch center?
We're second largest in the region, you know, for this kind of volume.
But 15,000 compared to what? I know we're probably looking at almost
we'd have-
$400,000
Yeah.
this year for dispatch.
Yeah.
It's not, I mean,
Yeah.
to even a regional center, I don't know how we could compete.
Yeah, and I'm not sure that we could. My concern continues to be if it bumps up by 28%, we continue to see cuts.
Where do we come up with it?
Yeah, you know, we're making trade-offs, and that's really challenging for every department. And
Yeah.
The department's no different. So, but I am aware, I saw it, I noticed it, I reached out, I asked the questions. They're not budging.
Here again, that's what we're gonna be listening to at 3:30.
Yeah.
We know those costs are gonna increase, and to go to even an outside agency or regional agency, it's hard to compete.
It doesn't make a ton of sense.
So, and that's a lot bigger number than the one we're looking at now, so.
Yeah.
Okay, anything else?
No, I mean, there was a letter released to the Joint Budget Committee from Michelle Barnes, the director of CDHS, and Dr. Lisa Roy, the department, the BHA. I don't know if you read it. I would be interested. Yeah, I'll send it to you. But of specific concerns, they were talking about the TANF allocation, CCAP, that's our child care allocation, and our child welfare allocations. And basically cost-saving measures, right? We're trying to figure out how we're going to make things work moving forward. I found it to be a really unique RFP. I felt like the state and the BHA basically said some things that were pretty infuriating as far as from a county level. And I know that as you all have those discussions at CCI, if you wanted my feedback about that letter or about some of the things that were said, I'd be really interested in giving it to you. The TANF allocation has not increased since 1998. And so even if we just looked at that alone, the expectation that in 2025, inflation, like we haven't seen an increase in that line. They indicated that counties were prioritizing they weren't prioritizing TANF in reasonable ways and meaningful ways, which felt like a big generalization. I think at one point during one of the hearings, they indicated that maybe some counties were funding soccer teams with their TANF dollars, which is like outrageous and not true. But it's really important conversations because as a department, we're going to cut TANF contracts again this year. We have to. There's no question about it. And those TANF contracts are serving the broader population to keep children in their home of origin. And those are really important. That's really important dollars invested into preventing children from coming into child welfare. The more families and children that come in, the higher the expenses. CCAP's underfunded. The new federal regulations, as you all know, have increased what we are paying out for quality child care, and that all makes sense, but we don't have the funding for it. There were statements in there that CFMS, which is the mandated accounting system, that we enter our own things and the state can't always see what we're really entering. Kind of like this vague indication that perhaps we're not entering accurately, which chaps my hide. It really infuriates me. And there was a section on that, in essence, counties have control entirely of their budgets, and that this overspending, and certainly I think for big counties that overspending is vastly different than what us balance of state counties look like, but that this overspending could be controlled, and that's not the facts. There are some things that we could stop when we ran out of money, but there's some things that we can't. We have zero control of those, like when we get those children that have to have psychiatric placements in child welfare. We can't say, oh, our allocation ran out, we have to stop spending this money. That's not how that allocation works. And so it felt a little frustrating, and I would certainly, if you're engaged in any of those conversations, they have the Joint Allocation Committee doing the work, the Child Welfare Allocation Team, the CWAC. They're really important conversations that I want to make sure that those making those decisions about that money really understand what it's like to be a balanced state. We're lucky that we're in the middle, we're a medium, right? So we can usually swing pretty fair, but small counties in particular have the hardest hits when they have those kids or those cases that require a ton. And so I just say all of that. If you see that letter, if you want me to email it to you, I'm happy to. But if you want input when you're having those broader conversations about the bills or some of the things that are going to come out in this next legislative session, I'd be happy to have conversations about what that looks like in the trenches, and that it's not as controllable as our CDHS director indicates.
Send that to me, and then I'll get with you prior to our first meeting up there in January, because the second day Fridays are always
Yeah.
I didn't look
HHS
I didn't look at the agenda for CCI. I didn't see it.
for the annual,
Yeah.
the December meeting.
I think they just released the CCI.
They just announced it. but
Yeah.
They haven't,
I don't even know that they have
Send us an
agendas
agenda.
yet.
yeah.
I know the JAC that is meeting regularly. They had a meeting the week before last that I attended and listened to. CWAC continues to meet. Those happen at CCI. But I think there's some really great commissioners that are on those that have a really firm understanding. But I also really want to ensure that when you're talking about the balance of state, what it looks like really here, I was very dissatisfied on
And
their
that was sent to the
recommendations.
JBC or the,
Joint Budget Committee.
Yeah.
Yeah. I was it felt very negative towards departments being county ran, and left it with this like open, maybe like we're going to imply they're not doing what they need to do. And I don't appreciate that.
Maybe the
That's not
state's
accurate.
doing what it needs to do.
No,
well,
it's not.
they're just looking
When are they
at
gonna cut
cutting,
their staffs?
that's what they're doing.
Yeah,
If they're
They're trying to put it
sending
off
that
on
kind of a
us.
letter, it's gonna go back to the counties, so the JBC is gonna cut it.
Yeah.
And that's why I want to
That's-
make sure that you have the awareness to know, like, some of these things are out of our control. And we do our very best every year to make a balanced budget, to make sure that we're accounting for, whatever could come. But we're also doing more with less. When you see an allocation line that hasn't had an increase since 1998, and you expect us in 2025 to be doing the same business with this amount, like, that's not realistic either. I could go on, but.
You can bet their staffs and their offices are not doing with what they did in '98.
Well, Commissioner Lindsay, I'll let you know that the state, because we asked, what are you doing
Yeah.
to cut your budgets? You're asking us, and we're doing our best. What are you doing? And they let us know they're on a hiring freeze. The week before last, I was on a meeting about the HR1 impacts and some policies that are going to come with those, especially for our economic security team, which is a big deal. We need to know what we're doing and how we need to do it. And Shelley Bankert, who is the Director of Economic Security for the state, let me know that they hired an entire team.
Yeah.
It was
Can't
only
make a
a freeze,
decision,
it
so
was
you
only a
appoint a
freeze for a
committee.
day.
And when one of us directors said, we thought you were on a hiring freeze, how does this align with where we're at financially in solving these problems? Shelley said, well, we're hoping that this team of analysts will be able to give us enough ideas that we can save money down the road.
Then why don't we get rid of the people that are in there and hire this team to take their place?
And
Send
so it
send
left
me the
me,
letter
it
and
left
we'll
me
have a
feeling very
conversation.
frustrated at what Michelle Barnes and Dr. Roy sent forward. But besides that, all is really fabulous. We picked apples for senior services. They're gonna do a apple fundraiser.
All right.
So we got to pick apples, so you'll see.
When did we get to pick apples for CSU?
I think they
Is
did
that-
That was,
already.
that was
Oh,
the,
that
that
was-
was on the
yeah.
20th. We got to go on the 19th, and a variety of seniors from Mancos, Cortez, and Dolores, we all went down. We plucked 800 pounds of apples, and now they're gonna
So
work
did you
on.
guys go?
I didn't go. I seen the deal come through, but I couldn't go.
I didn't see it.
It was really fabulous. It was great for the CSU to do that, to give us those apples. We had a really good time.
Nice.
It was a lot of fun.
That was this weekend.
Yeah, it was. We went on the 19th. Yep.
Yeah.
Well,
was on the
very good. I
20th.
missed it this year then.
Yes. But
All right. Thank you, Kelly.
Buy beans, they're cheap. Price of beans went down. Pinto beans off,
That was a long 2 minutes.
yeah,
I'm sorry. I'm gonna leave this one up here.
okay.
All right. Thanks.
Thank you.
James Dietrich, come on down. Looks like you're going to give us something else to think about too. I read all of this. So take it away.
Okay, good afternoon, gentlemen. So I just wanted to let the commissioners know, I think we've got a problem with the CPW grant. It really has to do with the timing of this grant. So, and let me give you a recap on where we're at with everything. So FLAP has 10.8 million programmed for 2028 construction on the Mancos side. Our local match requirement is 3.5 million. We have 1.7 million lined up, and that leaves us with a gap of 1.8 million. And that's because we lost that MMOF funding. So to fill that gap, we were planning to request 1.5 million from GOCO, and we're expecting to hear about that decision in December. That grant has been applied for, so that's all in process. And then we were also planning to apply for $250,000 from CPW, which would help us meet the entire match gap. So the grant is due October 1st. I have the grant all prepared. It's ready to be turned in. The problem is that we're required to do a presentation in Denver in January, and prior to that presentation, we're supposed to have all of our federal clearances and environmental work done. However, as you know, some of those clearances have a shelf life, so about a year shelf life. So CFL HD doesn't want to do all those clearances until right before construction, because if we did them ahead of time, then we'd have to redo them before construction. So that leaves us with a problem with CPW. They don't seem to have any flexibility on that. They're just demanding that work be done. So I guess my recommendation is we should not apply for the CPW grant at this point. We should wait until December, find out whether or not we get the money from GOCO. If we get the money from GOCO, then what I think we ought to do is just tell CFL HD that we can cover that $250,000. That would we'd have to enter into a new MOU with CFL HD, but the $250,000 acts as a placeholder. Because then later on in 2027, then we can reapply to the CPW non-motorized grant to see if we can land that $250,000 back, and that would cover the entire gap, and we wouldn't be out any funding at that point. So essentially, yeah, we'd have to delay that CPW grant is what we would have to do. And again, we don't have to make a decision about this immediately. We can wait until we find out in December about the GOCO grant. If we don't get that GOCO grant, then I would say that is a fatal flaw for the project, and we just have to pull the plug.
Okay. Should we name this a legacy project?
It's a legacy project, yes.
How long has this been now? 12
Been
years?
11 years that I've been
11
working
years?
on it. Yeah,
Oh, this has been going since,
yep,
this is a 25-year project.
absolutely. Yeah, it's a forever project, yes.
Yeah,
Been a third of my career working on this thing.
yeah.
Yeah.
And we haven't turned any dirt yet.
We haven't turned any dirt yet. What we do have though is we have shovel-ready plans, and by this time, by spring of 2026, we'll have shovel-ready plans for the entire thing. And so, at that point, if we run into a fatal flaw with GOCO and have to pull the plug, well then at that point, we've got plans that we can provide to the city and to the town of Mancos. We can start looking at smaller chunks of that trail to try to do at that point.
I know last week the city just signed a support letter.
Yes. Yeah.
I think, and Dolores signed a support letter too.
did.
So I think, talking about the segments, the segment A, segment A, B, and C, right?
A, B, C, and D.
And D. So D is on the Mancos side, A is on the Cortez side.
That's correct. C and D are on the Mancos side, yes. And
Right,
that's what
but-
we would be asking for the construction dollars for.
For C and D.
Correct.
Which ties us all the way to the,
That would get us from Mancos to Mesa Verde entrance.
Mesa Verde, that's right.
Yeah. And of course, on the Cortez side, what we would want to look at is probably the high-value section, which would be segment
Which would be
A, from
segment A,
Denny Lake
to the fairgrounds.
To the fairgrounds, yeah.
Gosh, even if we can get a segment done, I think it would catapult this thing forward.
I certainly
Because there's a
think so,
lot of
too.
use between Cortez and Mancos that would benefit the county,
Right.
but there is a cost to it.
And so FLAP has another call for project that's supposed to be released in 2025. So, ideally, if we get the GOCO grant, we start moving things forward. We're scheduled for construction in 2028 on the Mancos side. We apply for the FLAP funding on the Cortez side in 2025. I would start looking only at segment A, make that a smaller piece. It's more complicated. We've got 2 water crossings and we've got an underpass to do on that segment. So it's going to be expensive. But then if we can get ourselves into the hopper on that one, and I don't know when construction would happen, it's probably similar to this one. I think they schedule those for like 5-year periods. And so if we land a FLAP grant in 25 or even 26, then, we're looking at probably 2030 for construction on anything on the Cortez side, so.
I was in a Region 9 meeting last week, and I can't remember the year. It's either 28 or 30 that the World Mountain Bike Championships are going to be in Durango. And then there's a couple of events in years prior to that lead up to this. Now, I have it written down, but I don't remember what they were. So this would kind of tie into some of that.
Yeah, it sure would, yeah.
So the recommendation, just to make sure that I'm writing this down right, because it's on the consent agenda tomorrow, is to not submit at this time the CPW grant,
Correct.
correct?
Yes. Then we'll plan to apply in 2027, which would be right before the construction period. And that way we get all of our clearances done right in the correct time frame. And, and hopefully we land that, which, I think the danger is, I'm not sure it's a danger when we could decide not to move forward with it. But what we are doing in January would be committing the $250,000 from the county to get the project built. But again, that would be a placeholder in hopes that we land that grant and then we've got the $250,000 back. So anyway, we can kick the can down the road in a sense, for the decision on construction. And in 27, I guess if we don't land the grant, then we could decide at that point whether or not we move forward or not.
Okay.
The critical piece, though, is that $1.5 million from GOCO. If we get that, then we're still in the game.
Yeah.
So,
But we still have a $1.8 million gap.
no, we
Oh, if we
we
get
would
that-
have a $250,000
The
gap.
$250,000
Correct, yeah.
gap, okay.
Yeah.
All right.
Okay, and do we want to make a decision tomorrow on this, or do we want to wait until
Well,
December?
I think your recommendation, that's why I asked, because it is on the consent agenda
It is,
for tomorrow.
yes.
So if we approve the consent agenda as it stands, it would be to not submit for the CPW grant currently.
Correct, okay, that sounds
And
good.
that's what I have written down.
Okay.
So
That sounds
that's your
good.
recommendation, that's on the consent agenda. We can pull it off and discuss it further if you guys want to. If not, that's basically what we're approving, is that we do not submit at this point in time.
Correct.
And tomorrow, if that's the way we go, we'll just make sure that we
Yeah.
articulate that appropriately, that that's what we're doing.
Okay,
And that's why I was writing it down, so that way we just make it very clear that at this point in time, we're not gonna submit the CPW grant,
right,
which is due
Okay.
Wednesday.
yes.
Okay.
And then in January or into December, when we find out whether or not we have that GOCO grant, we should reconvene, discuss this again, and let CFL-HD know whether or not want to commit the 250,000, and that should be the placeholder that we need until 2027.
I'm telling you, if I walked out there for 2 hours with a pack of lath on my back, I could get that trail built in 30 days.
Yep. I know, we've all been saying that. Yep.
Anyway, okay, anything else?
Nope, that's it. Thank you,
All right,
gentlemen.
thank you, James.
Right.
All right,
Thanks, James.
seeing no further items on this agenda, we are adjourned, gentlemen. We'll be back at 3:30 as the E911 board. We will continue to go. All right, everybody, we are back, but we are back this afternoon as the E911 board. And with that, we have updates
We have some business to take care of before
and
that.
maybe a funding decrease request by Lori Johnson.
We have to do this first.
Oh, did I not read that right?
Yeah.
Okay,
I would so move we approve the minutes of the previous meetings of the E911 board.
Second.
it's been moved and seconded to approve the proceedings of the E911 Board of Commissioners for Montezuma County for November 4th and December 16th of 2024. Is there any discussion?
No.
All those in favor?
Aye.
Aye.
Thank you.
You're welcome. And with that, Lori, you can take off.
Okay, for updates, the biggest update is on the phone system. You know, we've been battling that Site B, the secondary location, since August 2 years ago. And they let me know this week that they're ready to test it. They think they've got all of the bugs worked out, and we'll be testing it on October 16th. And if all goes well, then I'm sure they're gonna be coming asking for the remainder of the money for that contract. So that the remainder is $155,547.42, and it was approved 2 years ago.
Yeah.
So it'll just be coming out of the budget this year. And then
Will
Sheriff.
take as long to pay them as it did to get it in
Yeah,
service.
to get it in. Well, I don't know if we can do that, but okay. And then Sheriff Don Wilson wanted us to know that he's got everything installed in his new dispatch center, and I think he's gonna, I don't know if he has yet, but he wants to invite everybody out to look at the center, because he made some changes to it himself, some structural changes to his dispatch area. So they're now behind glass, and he just increased the safety for them.
Yeah, we were, what meeting were we at there when we walked through that dispatch center? Prior to us approving all of these consoles to go out there,
Wow.
it was pretty wide open.
Yeah,
I mean, it was,
yeah. And I think, I haven't seen it yet, but I think the way he talks, it's now more secure. He feels better about his dispatchers being there alone at night, so. And he said the radio system's working great. That really saved him a lot. So
Good.
he's very appreciative of that. And then the next reason we're here is, and I'm sure y'all read my memo, but at the last, what do we call it, Communication Advisory Council meeting, we went over the budget. I should say Randy went over the budget with them, and there was some discussion then about if we could get the 911 board to put money back into that fund to offset the cost to the user agencies. Now, we've been doing that we've been putting 85,000 into it right up. I think I checked with city finance in 2020 was the last time that we collected the 85,000 from the 911 fund. And I think that, I don't know for sure, but I think that was because we were purchasing the radios then, and that fund was kind of drawing down. So we felt like it needed to stop for a while.
when was that again, in 2021? Is that what you said?
Yeah, 2020 is the last time the city actually accepted a payment for the 85,000. Now, at one time, they were collecting $122,206, but we went back through the minutes and we never could find where the agreement was made for that extra, what would it be, $37,000. So we dropped that probably in 2018 or 19, I think. We dropped that and brought it down to just the 85,000. And so I guess I'm here requesting that we just reinstate the 85,000 to help the users out in offsetting their cost a little bit.
So obviously I see the statute here, the 2911-104, which gives us the ability to go ahead and utilize that.
Yeah, yep, for personnel.
For the
In
personnel,
the
but we
dispatch.
can move it basically annually or anytime that we feel that we need to. Is that,
Move the
I mean,
money?
well, no, we have to, we can approve it
Yeah,
or we could disapprove it.
correct.
But we have enough money looking at it that we can afford the 85,000 to put it back into that,
Yes.
correct?
Yeah,
If I read that
I did a
properly?
kind of estimated projected budget in this. I worked with Robert some, but this is my projection, it's not his.
Mm-hmm.
And we will do, there won't be any problem until about 2029 after the purchase of I shouldn't even say purchase, but the upgrade that we're gonna have to do to the radios. The fund, if you take the reserve out, the 500,000, the fund will go down to $258,800. However, I feel like I feel like I've estimated everything pretty high, and if I did, then that fund won't go that low at all.
Good.
And there's also I don't even know if this is a thought, but we're collecting $1.97, I believe, for the surcharge fee. And currently, we could go up to $2.12. But I think that would have to be decided by October, and then we wouldn't start collecting it until
I thought
July.
we were at the maximum right now.
Do what?
I thought we were at the maximum right now.
I thought, well, we were until I think last year they went up again. But I can double check that.
Double check that.
Yeah,
What kind of revenue would that bring in? Have you done a calculation on that?
I really haven't did a calculation. It would be what, 15 cents per phone line, so,
Every line,
yeah.
whether it's a hard line, cell
Yeah.
line, everything, it's every
Correct.
line, which
Yeah.
could be pretty substantial.
I understand Durango, and they had to do the whole process, but they went up to $3-ish, right around there, collecting $3 per phone line, which seems kind of steep, but
Yeah.
they have two centers that maybe three centers that they're funding, because they have their backup center, their primary center, and then the Southern Ute Center is part of their authority board.
Okay.
So I guess today, if you pull up this page, Travis had asked that we show how that breakdown would be of the 85,000. And so on the third page of Randy's PowerPoint, it shows kind of the breakdown of who gets what, how that money would be divided.
So these are all based on percentages, Randy? Is that,
That's correct. Percentage of call volume from 2024.
And
mean,
Of
I
course,
don't,
the biggest benefit is to the county and the city because the
we're
two
the
are
biggest
like
users.
70% user of the
Yeah.
use of the center.
How much, I thought we were like 80% with both of us.
I
Real
think
close?
honestly, I think it went down.
It's pretty close to
Yeah,
80%.
like, say 40-40. I know it's not exactly that, but it's pretty close.
Pretty close.
Oh, that's right, 37 and 42 maybe.
42,
Yeah, it's
43. Yeah,
pretty close.
right about there.
40-40. I don't have any issues. I mean, we have the money there to put that back as long as we're following the statute. I don't see that would be out
I
of
don't either.
line with anything.
I think it would make the users pretty happy.
Which is,
The smaller users
well,
and the big users.
well, the
but
big users too. I mean, we're
Yeah.
still, between us two here, we're the lion's share of the entire cost.
Right.
I don't think I have any issue with that. I guess we
I
need
don't.
formal action since we actually are a 911 board right now.
Yeah, we can do that.
So we can do that today. And then that you could actually then include it in your
Billing.
numbers.
that they can-
So I guess that's what I'm asking, is that's your ask?
Yes,
Okay.
Yep.
So
we would
re-
like it for the 2026 budget
Correct.
year.
Okay. All right, you got it?
I would so move that we reinstate the $85,000 payout from the E911 funds for dispatching services to the Cortez Dispatch Center.
Second.
2026. Okay, it's been moved and seconded to reallocate the $85,000 to the Cortez Dispatch Center out of the E911 Authority funds for the fiscal year 2026. Any further discussion?
Can,
All of them, go ahead.
can we make that an ongoing thing until we need to back it off? Or do
So
we?
I'd rather not tie another board's hands.
Okay,
I mean,
Just don't let us forget to do it.
I think,
Yeah.
no, I mean, you won't let us forget to do it. We probably could for next year, but then after that, I leave and I don't want to tie somebody else's hands. So I don't think it's a wise decision
Yeah.
okay,
to do that. I think it's easy to just bring it forward. Obviously, they'll be able to hear these conversations, so I think that
perfect.
it's better to leave it unattached. With that, all in favor?
Aye.
Aye.
Aye. Okay, that's approved.
Okay,
Thank you all for coming.
that's all I have.
Thank you all.
Appreciate your time.
Have a great rest of the day. Take care. Seeing,
We could
actually,
always find a meeting. We just wander around looking for meetings, you know.
so I'll have
I'm
a
sure the
motion-
city will have one somewhere we can go to.
adjourn this meeting.
Motion to adjourn.